This is Dr. Jyotirmay Maji. I am MBBS and MD in internal medicine. And today I will talk about most encountered problem in our outpatients and inpatients, that is hyponatremia. So let's see uh, whether hyponatremia is really a problem of sodium metabolism. Is it some disorder of some sodium channel? No, it is a disorder of water metabolism. So both hyponatremia, all these things are actually related to water metabolism. Whenever sodium enters into cell, it takes along some molecules of water along with it, that we have read in our 12th, 11th chemistry. And whenever it goes out of cell or somewhere, it is always carrying some amount of water like that. So sodium and water metabolism is um, um, sodium and water metabolism is very much linked to each other. So what is hyponatremia? It is a disorder of water metabolism. It is a disorder of water metabolism. Mostly sodium, actually there is no clear-cut value of sodium. It's mostly it is we take it as 135 to 140 is the normal range according to labs it varies. And the symptoms mostly arise, some patients are asymptomatic. You will do routine blood investigation in a patient with thyroid diabetic, mostly 60, 70 years old, and you will find hyponatremia in that patient. Uh, so mostly it is symptomatic when the level goes below 125 or 120. Again, it varies. Again, it varies. So mostly they are associated with symptoms. So most symptoms are initially starts with mild hyponatremia, that is around 120 to 125 to 115, 115 to 120, 25 milliequivalent per liter range. It is where you see the GI symptoms mostly. You see the GI symptoms like anorexia and nausea, vomiting, cramps, muscle cramps. You see, and then when it goes a little bit down, like 110 to 115 milliequivalent per liter, then starts the most important symptom to diagnose it early: ataxia. Ataxia. If you see some old patient in your ward or somewhere in the relatives, you will see that this is the thing they complain the most. The patient is not able to keep their balance. They will complain that there is a tendency to fall, ataxia. So that's when you have to think that this maybe the patient, you take the drug history and you have to investigate whether there is hyponatremia, confusion, dizziness, all that. And serious complications. See, hyponatremia, sodium disorders doesn't invite cardiac problems as such, but they cause some deadly neurological complications by increasing intracranial tension and causing cerebral edema. Cerebral edema. So which leads to seizure, and all other things, all other complications that we talk about. So at the center, this is, we can see water and sodium metabolism, uh, water and sodium metabolism, and homeostasis. So our body has this thirst center. Our body has this thirst center uh, that is situated in lateral hypothalamus, paraventricular nuclei, and periaqueductal gray matter. Periaqueductal gray matter. And it is being controlled. I talked about osmolarity. So these osmostats are present in anterior hypothalamus, OVLT, and SIPO. So what is OVLT? It is organum vasculosum, organum vasculosum of lamina terminalis. So where is it situated? It is situated above this pituitary gland, yeah, right here. So it is devoid of blood-brain barrier. It is devoid of blood-brain barrier. There is no blood-brain barrier. So it can directly sense the osmolarity. And why I am talking about osmolarity in case of sodium metabolism? Because water metabolism and such. Because sodium is the one of the most important cation in our body that is controlling your osmolarity. Osmolarity. That is controlling osmolarity. So it is one of the most important cation. So what happens when body senses that your osmolarity is more, so it will stimulate your thirst center, it will stimulate your thirst center. Also it is voluntarily, you can take water also. So body will trigger it thirst center. Thirst center will tell you to take water. You will take water, and your osmolarity will come down, and your sodium, your plasma will try to maintain that uh, normotonicity. Normotonicity. It will try to be normal. So that is one thing. And then another factor is there. Another factor is there. That is your uh, another factor that is important is your effective arterial volume. Effective arterial volume. So whenever your body senses that your arterial volume is low, arterial volume is low. So uh, arterial volume is low. So it will be sensed by so GFR will be low. So it will be sensed by your glomerulus, tubuloglomerular feedback. Tubulo, tu, your tubuloglomerular feedback will start to work. Your tubuloglomerular feedback will start to work, and your JG cells, etc., will be stimulated, and renin and angiotensin uh, and aldosterone system will work. So what will do aldosterone, your renin, RAS? What will they do? It will work on your collecting duct, and it will uh, trigger aldosterone. Aldosterone will upregulate your ENaC channels present here. So it will directly absorb the sodium from the collecting duct cells, and along with it, water will also come inside. That's how the body primarily tries to fine tuning of sodium water homeostasis. It is happening there. This is one mechanism. Then coming to the next, that is your sympathetic system. So whenever your arterial volume is low, or the body is in dehydrated condition, your BP is low, the sympathetic system is getting active, and your beta 1 receptors in JG cells will secrete renin. That's how it will happen. Posterior pituitary. So another thing is when osmolarity is increasing, it will trigger your posterior pituitary to release ADH, which will activate your aquaporin two channels. Aquaporin two channels, and it will try to conserve water too. So far we have known that ADH is acting in a big way. ADH is acting in a big way in your collecting dark cells mostly, and your RAS system. That is one of the most important thing. Your ENaC channels that is working in the DCT and collecting duct, DCT mostly, DCT and renal tubules. So we will see what are the other things related to natremia, where the water absorption is happening the most. Small intestine, I said, it's one of the most unregulated sodium water absorption is happening here, and SGLT1 transporter in the jejunum, sodium hydrogen exchangers. Aldosterone also works in a little way. Colon, it's one of the most important place of water absorption mostly, and not salt that much. Then kidney nephrons, 65 to 70% of your filtered sodium is absorbed here, and thick ascending loop health, where 20 to 25% is absorbed. NKCC2 channel. NKCC2 channel, it is a very important channel. Distal DCT 5 to 7%, and collecting of 3 to 5% is ENaC and regulated by collecting that and DCT. It is aldosterone. Okay, okay. Uh, And another thing that can come to your MCQ is bone. Bone is not a primary site of sodium absorption, but acts as a sodium reservoir. It uh, actually um, reserves sodium with salts, and it is exchangeable with extracellular fluid, plays a minor role in long-term sodium balance. So coming next, now hardcore, we'll talk about now hardcore hyponatremia. Now, what is happening What is hyponatremia? Actually, hyponatremia, when we will say this patient is having hyponatremia, so there are two things: true hyponatremia and pseudo hyponatremia. What is, why is it? During the discussion, initial discussion, I told you there is a concept of osmolality. It is very much related with sodium water absorption. So whenever sodium is low, your osmolality is also low. That is because it is one of the most important cation that is controlling your osmotic balance in body. So when sodium is low, osmolality is also low. Then we will say it is true hyponatremia. And pseudo hyponatremia, why it is pseudo? Because when sodium is coming, you at your lab report you are seeing sodium is low, but serum osmolality is high or normal. So why is it? Because of translocation. Because of translocation and other things, lab error. Translocation and lab. So translocation, why it is we are saying it is translocational? There is a concept of effective solutes. Effective solutes. So let's see. Uh, so so what is the concept of effective solute? Effective solute. So if your plasma these things, high glucose, the patient is having presented with decay, so patient has high glucose, or patient is infused with mannitol, these patients, so these components actually don't go into your cell freely, they don't move into your cell freely. Okay, so what are they creating here? They are creating here a osmotic gradient, they are creating here a osmotic gradient, osmotic gradient, osmotic gradient here. They are not freely moving. So here your intracellular, so here solutes are more, they are not really moving, so they are creating a high osmolarity. Now water will come from here to here, cell to outside. So locally we will, this will create a uh, environment of dilution. So this will create pseudo hyponatremia. Pseudo hyponatremia. Okay, pseudo hyponatremia. So this is mostly error of judgment. And another thing, so the important things here, which molecules can cause it: glucose, mannitol, maltose, glycine, etc. Okay, not but alcohol. Alcohol is not a effective solute because it can move into cell freely. Freely. Okay. And there is another thing: high lab error. Lab error in it is a high amino acid contained in blood or in hypertriglyceridemia, it can create lab error also. Okay, pseudohyponatremia. So whenever we are saying hyponatremia here, further on, we are saying true hyponatremia. Okay, moving to the next thing. So uh, now this is a chart from Harrison where we are seeing whether the patient. So now we are saying hyponatremia. That means true hyponatremia. So what will happen if we see suppose you are seeing a patient of a marathon runner who has during marathon, it's on a sunny day, he was running and he took only water, cold water, and he suddenly fell down with seizure, and immediately the emergency docs came and he was taken to hospital with diazepam and all, and ABG which shows this there is and lab report shows hyponatremia, sodium is 105. So what is your management outcome? So before that we have to know, and another patient is having suppose patient of decompensated liver disease. The patient is totally edematous now, and he is also having a little bit of ataxia now. You see, sodium is like 120, 121, 180. So the patient is on diuretics also. Patient is on aldactone, etc. But he is having this. So the management approach will be different in both cases, a little bit different. So to treat these patients scientifically, you have to know how the pathophysiology is working and how they are classified, these hyponatremia patients. So they are actually classified on the basis of their volume status, body volume status, hypovolemic, euvolemic, and hypervolemic. So what is happening in case of um, hypovolemic hyponatremia? Total body water is also patient is losing, and total body sodium is also they're losing. Okay. So they are losing both total body water and total body sodium. And then there is euvolemic. Euvolemic, they have no edema. They have no edema. Patient is having like a patient is on elder patient having is on Nexito plus like escitalopram, and he has been started on 3 months for escitalopram and clonazepam, and the patient comes with recurrent fall, ataxia, and confusion, and you see this patient is having hyponatremia, but the volume status is completely normal. So that is one different case, that is euvolemic, and we'll see what are the causes of euvolemic, hypovolemic, or hypervolemic is I said DCLD like this congestive cardiac failure, or CKD patients in volume overload state. Total body water is so high and total body sodium is increasing, but it is not increasing that much. Saltwater retention is happening in DCLD patients. Is the most important mechanism. RAS system is overactivated. That is called overfill theory. But the water content is more than the sodium. So that's why the patient is having hypertension. This is a total game of concentration. Okay. So hypovolemic hyponatremia. So whether these patients are having renal loss or GI loss, we have to see that. So or other system loss, like so how will we assess that? We'll assess that by urine sodium. Urine we can do in our indoor patients. We whenever the patient comes, before correcting, we just send a stat sample 24 hours sample lab. It's running, send the sodium. So it is urine sodium if more than 20 milliequivalent. So you are seeing that that is renal loss. So how renal loss is like due to diuretic excess or mineralocorticoid deficiency like cons, or salt losing nephropathy, any tubulopathy like AKI, etc. also happening. The renal tubular acidosis, ketonuria, osmotic diuresis, cerebral salt wasting syndrome. We will talk about this later. And urine sodium is if less than 20, patient is hypovolemic, the skin temperature is low, patient is tachycardic, and you see your underarms are dry and BP low. So these are the things that, and you take proper history of that patient is having diarrhea, vomiting like that. So extrarenal losses like GI losses like vomiting, diarrhea, third spacing like burns or pancreatitis, trauma, patient have lost so much blood volume like that. So euvolemic hyponatremia, the number one cause coming is syndrome of inappropriate antidiuretic hormone secretion, or we can say CRD. CRD is the most syndrome of inappropriate antidiuresis rather than antidiuretic hormone, because we'll say about that later. SIADH or SIAD or SIAD. Okay. So, and other causes are important causes. Glucocorticoid deficiency in case of mostly exogenous Cushing, where patient has been withdrawn from steroids. That these patients can be present to you with low sodium and high or high normal potassium. These patients, and with that thing only, you can look at this patient and you can get some history that patient has taken some alternative medicine which contains steroid. So that's way. That's how we diagnosed so many patients of exogenous Cushing's. That is one thing, and the secondary adrenal insufficiency due to some pituitary tumor. So your ACTH is low and your cortisol is low. So that's one thing. But primary adrenal insufficiency, mostly the patient will lose volume too because of aldosterone deficiency. Okay, hypothyroidism will give the explanations, drugs, stress, etc. And hypervolemic hyponatremia, urine sodium is more than 20, is acute or chronic renal failure, and urine sodium less than 20, nephrotic syndrome, cirrhosis, cardiac failure. These are the holistic approach. Now we'll see hypovolemic hyponatremia. We discussed about this. Urine sodium more than 20, renal causes. So renal causes, high urine potassium is coming. So then renal tubular acidosis, AKI in diuretic phase, salt losing tubulopathy, cerebral salt wasting, low urine potassium, hypoaldosteronism. Because your aldosterone is not working, so your sodium, your potassium will get conserved. Your potassium will come inside cell. So urinary sodium is less than 20. Other causes like GI that I explained in the chart. So now, so we know about hypovolemic hyponatremia. We will take some history. whether the patient has been on excess thiazide diuretic. Is a very notorious thing, thiazide diuretic in old age, more than 60, 70 years. Many patients, they can't even tolerate, we will give the patient on some CT or telmisartan CT like that, telma CT or H like that, hydrochlorothiazide, chlorothiazide, whatever they say, it causes hyponatremia very much. Okay, so now coming to euvolemic hyponatremia. This is euvolemic hyponatremia. Okay, euvolemic. So one of the causes that I told you about hypocortisolism, glucocorticoid deficiency, like secondary adrenal insufficiency, where glucocorticoid axis is disrupted, and hypothyroid, and another is CR or SIDH or CR. Okay. So one thing I will discuss here, I'll try to discuss here. Uh, so Addison's disease can also cause hypertrophic disease. But I told you primary adrenal insufficiency, also known as Addison's disease, is due to destruction of both adrenal glands and is characterized by inadequate secretion of cortisol and aldosterone both. So hyponatremia here is due to increased secretion of ADH. Why it is happening? Because uh, it is happening because cortisol cortisol is not being produced here. So without cortisol, what is happening? This feedback inhibition of, because cortisol inhibits this CRH which is being secreted by hypothalamus, and CRH is stimulating ACTH secretion from pituitary. So CRH inhibition is gone. Now CRH is increased. CRH will cause ACTH release, and CRH also causes release of ADH. So it will increase ADH level too. Okay. Uh, So what is happening here? Evolving hyponatremia instead that glucocorticoid deficiency, like secondary adrenal insufficiency, where only one axis like one axis like glucocorticoid axis is gone. So what can, because ACTH doesn't control your RAS system, actually it is controlled by a sympathetic system and different it is controlled. So how it is creating a CR like situation? It is creating because, yeah, I've given the explanation. So what is happening uh, is your hypothalamus your CRH is secreting, it is stimulating both ACTH and is also stimulating your ADH. Okay. So, and it is having a feedback inhibition by your cortisol, which is produced by your adrenal gland. Okay. Now, this feedback inhibition is gone. Okay. This is gone. So, what will happen? CRH will be unchecked. It will increase ACTH. It will increase ADH. So, this ADH will create your, um, it, uh, it will absorb more free water. It will absorb more free water. So that's one mechanism. And but you can ask one thing, that in such situations like CR or glucocorticoid deficiency, why if there is free water absorption, why it is not leading to such situation like it is not creating hypervolemia? Because it is not happening because of a mechanism called vasopressin escape. So when such situation is there, what is happening? Your aquaporin 2 channel, which is being stimulated by V2 receptor ADH, this aquaporin 2 is desensitized. It is desensitized. It is one thing. And also another thing is, when your volume is increased, your blood volume is increased, effective arterial volume is increased, two things are happening. Your RAS is again working, RAS is inhibited. Okay. And another, so water sodium will be in urine, it will be excreted. So that's why in CR you are getting urine sodium is high. Okay, because of this system inhibition. And another thing is natriuretic factors. Natriuretic factors, right? Actually, natriuretic factor. Okay, this is one. So we'll see other situations. Now coming to evolving hyponatremia, and another situation is hypothyroidism in moderate to severe hypothyroidism. Mostly hypothyroidism is nowadays diagnosed much earlier, so we don't see such situations. I have seen in my PG life 2 or 3 cases of like that. Okay. With correction, with correction after achieving a euthyroid state, severe hyponatremia can also be a evolemic hyponatremia can occur in euthyroid state. Okay, and severe hyponatremia can also be a consequence of secondary adrenal insufficiency due to pituitary disease, whereas the deficit in circulating aldosterone in primary adrenal insufficiency causes hypovolemic hyponatremia. So, in primary adrenal insufficiency, you are having hypovolemic hyponatremia. In pituitary disease, mostly secondary adrenal insufficiency, or in those cases, you are having evolving hyponatremia. Okay, okay. So, and another thing, proposed mechanism of hyponatremia in case of hypothyroidism. So interstitial mucopolysaccharides are increased. So that's why water absorption is less. Effective arterial volume is being. This is the same mechanism. Effective arterial volume is being reduced by which intestinal water absorption is low. Peripheral venous resistance is more, and also cardiac output is directly reduced by both cortisol deficiency and hypothyroidism, both, because these things can help in maintaining your cardiac output. So what is happening when cardiac output is low? Your body sensing that. So effective arterial volume vasopressin is increased. Renal aquaporin two channels are upregulated. Water absorption is free water absorption. And another thing, renal blood flows reducing, EGFR reducing. So what is happening? Water excretion is being low because RAS is not working, RAS is inhibited. So that is leading to hypernatremia, and this free water absorption is leading to euvolemia. Okay. And also one mechanism, sodium potassium ATPase activity in kidney is low, so tubular sodium reabsorption is low. Okay. Uh, why euvolемia in CRD? I have told you. Okay. And another thing is ADH is uricosuric. So whenever you are having CRD, serum uric acid is mostly low because ADH when increased, it leads to uric acid excretion. Okay. That regulates the uric acid transport. So causes of SIAD, syndrome of inappropriate diuresis. Uh, so this is SIADH. The mnemonic is SIADH only. Okay, so mnemonic is SIADH. Sepsis, S for sepsis, I for infection. Any infection, you will see most pneumonia patients or severe UTI. You see these patients are having CR. Anomaly, cerebral arteriovenous malformations, one cause, and acute intermittent porphyria. D for drugs, and H for head trauma. Head trauma has a triphasic response. So initially with trauma, your stalk is injured, so that's when your all the hormones are excreted, so you are having a polyuric phase and like that. It is mostly discussed with diabetes insipidus. Okay, a patient will have hyponatremia, then hypernatremia, and then again hyponatremia like that. Okay. Respiratory causes like asthma, positive pressure ventilation, and pneumothorax are most important. Another, so drugs causing SHIAD. We are having a mnemonic for that also. SHIAD causes poor voiding. So SSRI, S for SSRI, I for indomethacin NSAIDs, A for antidepressants like TCA, okay, fluoxetine, not always. That is D. Desmopressin, H hormones like high dose oxytocin, C for cyclophosphamide, clofebrate, carbamazepine, and chlorpropamide, carbamazepine induced vaccine, phenothiazine, phenytoin. B for vincristine, oncological drug, important. Okay. Paraneoplastic SIADH, paraneoplastic type A, which causes type A SIAD. So small cell lung carcinoma, very important. GIT cancers, any type, genitourinary tract CAs, prostate CA, etc. Urothelial CA, thymoma, sarcoma, lymphoma, sarcoidosis, sarcoidosis. Okay, sarcoidosis. So these are very important. The causes of SIDH very much direct questions. So, what is the diagnostic criteria of SIDH? So, what will happen from what we have understood so far? What we have understood so far, what will happen in SIDH? SIDH, what will happen? Uh, your if the patient will have euvolemia, but water will be more than sodium. So, what will happen? Serum osmolarity will be low. Okay, urine osmolarity go up. And next, what will happen? Your uric acid, I told you, which is a supplementary criteria. Uric acid will be low because ADH is uricosuric, and and urine sodium will be more than 20. And other causes like cortisol, hypocortisolism, or hypothyroidism, these should be excluded. Diuretic use, patient should not be in diuretic, not diagnosed in diuretic on the patient who is on diuretic because excess diuretic will also increase your urine sodium and it will cause hypovolemic hyponatremia mostly. Okay, so let's see the criteria. So SWORD diagnostic criteria it's from D group, textbook of endocrinology. So what is happening in measured decreased measured serum osmolarity, measured serum osmolarity. Uh, so why they have called this measured? Okay, why are not they calling it calculating? Because serum osmolarity, what should be done? There is a formula called 2 into sodium plus blood glucose, by 18 plus blood urea nitrogen by 2.8. Okay, there is a formula like that, but it doesn't work all the time. You have to do freezing point. You have to check serum osmolarity in freezing point technique. Within 10 to 20 minutes, you have to take it into some endocrine lab and you have to test it properly. So that's when it will give proper result. So normal value is 275 to 295. It may vary. Okay, right? 10 it may vary. So less than 275, they have taken these criteria as decreased measured serum osmolarity, clinical euvolemia, urine osmolarity more than 100, and units are important. And urinary sodium more than 40, so we take in lab 20 equivalent per liter. Normal thyroid adrenal function, normal renal function, exclude use of diuretic agents, no hypokalemia, no acid-base disorders. That means supporting diagnostic criteria, abnormal water load test, and etc. These are not plasma ABP level is not measured that much. And supporting diagnostic criteria like uric acid, low uric acid, and blood urea nitrogen less than 10. FeNA fractional sodium excretion more than 1%, fractional urea excretion more than 55%. Failure to improve or worsening of hyponatremia after 0.9% saline infusion, improvement of hyponatremia with mm, water restriction. Okay, so these are the Swatch diagnostic criteria. This is important, and there is one test, abnormal saline loading test, that is not done that much. Okay. So one thing that is goes hand in hand with CRD, cerebral salt testing syndrome. Actually, it is in sometimes it becomes indistinguishable at your ward. After in like I told you, head trauma patients after neurosurgery, the patients are having this thing called cerebral salt twisting syndrome. The patient can have CR also, patient can have this also. So what is the key difference here? Patient is, we see the pathophysiology first. Within 1 to 2 weeks of head trauma, it is happening and resolving within 2 to 4 weeks. Mostly self-limiting. Okay, uh, mostly conservative management is okay. So what is happening? Pituitary surgery or trauma. Okay. So what is happening? Sympathetic input to kidney is lost. Renal tubular sodium resorption is not happening, and renin aldosterone release is also reduced. And natriuretic factors like C and P, C type, not this, C type natriuretic factor, C type natriuretic factor. Okay, this is increasing. This is increasing. So it is causing natriuresis, and also volume is getting lost. So there is a triad. There is a critical triad that is called hyponatremia, hypernatriuresis, Hyponatremia is happening in CRD also. Hyponatreuresis is also happening. But here the another critical difference is hypovolemia. The patient is volume lost. Okay. So they are confusing so much that sometimes they are managed in both uh, in both ways, like the patient, if patient is given saline and urea also. Urea will help in CR. It will help in reducing water reabsorption, and you are giving initial saline also to counter this hypovolemia. Okay, so there's a difference of diabetes insipidus, SIADH, and cerebral salt wasting syndrome. So in CR, what is happening? Urine output is um, low, so not slow, and urine osmolarity is high. This is important. Urine osmolarity high, and here also urine osmolarity high because of net salt losing. Because salt and you are losing salt very much. All types of salts. Okay. Volume status. Here volume status is high. It's not high. It is. It should be euvolemic. Euvolemic. Here volume. This patient is losing volume. Hypovolemic. Okay. Serum sodium is low in both cases. Urine sodium is also high. Serum osmolarity low here also. Okay, quite similar presentation. So, so what is happening in case of a so what is happening in case of a pituitary surgery or head trauma? Sometimes you are having a triphasic response. You are having a triphasic response. So this is your pituitary. Suppose. Okay, this is posterior pituitary. This is stalk. So stalk, if it is injured, what is happening? So ADH hormone is actually is coming through this and getting stored here. So initially it is the stalk is injured. What is happening? This ADH cannot transport and there is a disturbance in flow. So initially DI is happening, diabetes insipidus. Then this is the first phase. Then what is happening? Also, you can have CSWS, cerebral salt wasting syndrome, polyuric waste. Then you are having a ADH is getting released, stored ADH is getting released, and you are having CR. After that, again DI. Okay, this is the triple response. So now we will move into the management of hyponatremia. Okay, so treatment of hyponatremia actually depends on the onset. Okay, treatment of hyponatremia depends on the onset. So the patient, if it is acute hyponatremia, that is less than 48 hours, then we should do aggressive treatment. Chronic hyponatremia more than 48 hours, we should be a little bit conservative. So what does it mean, aggressive treatment? It is meaning 3% NaCl. We'll have to correct the sodium quickly, 8 to 12, 8 to 10 to 12 uh, milliequivalent per liter in 24 hours. That is the target. So the patient is having 100, so we'll try to reach it by 108. Okay. In 24 hours, not more than that. Why this 48 hours timeline? I will explain it. Chronic hyponatremia, 4 to 6 milliequivalent per liter in 24 hours. 6 to 8 or 8 to 10, like that. Acute hyponatremia, 3% NaCl, 3 bottles, 100. If it is 100 ml, we will try to each 100 ml will infuse in 10 minutes. 10 minutes, 3 bottles. Okay, 30 minutes. 30 minutes, 3 bottles. Okay. And Vaptans, we see that in most of the cases you will see hyponatremia patient is starting on has been initial days here. At first, if it has been given tolvaptan, it is totally useless and it can cause more harm because haptans are useless in such setting. Acute hyponatremia doesn't work that fast, and Also, there is a risk of hepatotoxicity, and it will not work in acute setting. And mannitol, if you didn't try, it is also contraindicated. So I'll try to explain it. For that, I'll try to tell you about this protocol of acute hyponatremia in CR. So what is happening? They are considering is it is a NEGM 2007 protocol, less than 125 millimole milliequivalent per liter. If they are taking it severe hyponatremia and severe hyponatremia with severe neurological symptoms like acute acute hyponatremia, coma, seizures, etc. What will you do? 3% NSA. Okay, you can, in benefit of doubt, you can give a little bit of furosemide 20 mg in case of CR actually. Okay, and then you start diagnostic evaluation. Moderate symptoms, unknown duration. You will send urine spot sodium. You will look at TSH. You will look at cortisol. Okay, all these things you will do, and you will start the patient on some normal saline, and normal saline along with a furosemide 20 mg. Aim for increase 2.5 to 2 millimole per liter per hour. Stop when serum sodium is 8 to 10 millimole per liter within the past 24 hours. Then you can start consider conivaptan. Conivaptan is not used in India that much. Tolvaptan or conivaptan is IV. Check serum sodium every 4 hourly at the infusion. So in asymptomatic, we can diagnostic evaluation straight away. So after 48 hours, what I've said, chronic hyponatremia, it is in starting. So you, if it is CR, you are suspecting, you restrict fluid intake, encourage dietary intake of salt and protein, and demeclocycline you can give, or urea, and vasopressin receptor antagonists like vaptans. And there is one thing, urinary sodium plus urinary potassium by plasma sodium. If this ratio is more than 1, then recommended fluid intake is less than 500, and minus 1 200 to 700, and less than 1 less than 1 liter per day. So this, in these situations more than 1, when this ratio, actually here only water restriction does not work, because your salts are getting, urinary sodium potassium ratio is more than plasma sodium. The salts are excreting more, so that way only water restriction will not work. You will have to keep oral salt also. Okay, and by vaptans you have to actively stop any ejection. Okay, so so vaptans. Now we will talk about vaptans. So vaptans have many mechanisms. Unselective mixed V1 and V2 action. Conivaptan, it is IV. V1 receptor antagonist, that is relcovaptan. V1b antagonist, nelcovaptan. And V2 is lixivaptan, tolvaptan, satavaptan, mozavaptan. Okay. So vaptans used when asymptomatic. Sodium is more than 125, actually not severely hyponatremic. Dose is 15 mg OD. You can increase it up to 30 to 60. You can take it gradually, mg per day, OD dose. And major side effect is hepatotoxicity. Discontinue if rising liver enzymes more than 3 times upper limit of normal. And max in chronic hyponatremic patients, you can continue vaptans. Most maximum duration is 30 days. Okay. Now, while we are talking about this 48 hours timeline, okay, so there is this important term, osmotic demyelination. Osmotic demyelination syndrome, ODS, which was earlier called central pontine myelinolysis. Nowadays, it is seen that nearly 10% patients can have extrapontine demyelination also due to rapid correction of hyponatremia. So, what is happening? So initially, when the patient is the initial time within 48 hours, so what is your body is a very good actually body can preserve your homeostasis very well. So what is happening when your your this is your, suppose your brain cell, and this is your plasma. So what is happening? 48 hours patient is hyponatremic. So patient is acutely hyponatremic. What is happening? So water go inside cell. So this will lead to brain edema and increased ICT. Okay, cerebral edema. Now, now what will happen if this persists? This such state of low osmolarity or hypotonicity persists. What will happen? These brain cells will start removing various organic anions, proteins, okay, urea, etc. Will start to excrete here. So it will come into balance. It will come into balance of tonicity with plasma, okay, with extracellular fluid. So, and this process is completed by 48 hours. So, if more than 48 hours has passed, more than 48 hours has passed, and you give this patient, suddenly you try to aggressively correct this hyponatremia, what will happen? This brain cell, it is currently has reduced its edema a little bit on its own. What will happen? You suddenly insert 3% NaCl, that is hypertonic. You create hypertonicity here. Okay. Now your cell is hypotonic than this, so your cell will shrink. Okay, water will come out of your cell. So what was happening initially was this plasma was hypotonic. This plasma was hypotonic and brain cell. Okay, here your water was increasing and it was edematous. Now what is happening after rapid correction? This is hypotonic and this is hypertonic. It will try to excrete water into your ECF. Okay, so that will cause brain herniation. There is a deadly complication. One thing is brain herniation, and another thing is this insult will cause your osmotic injury to your myelin. Okay, around your pons, it will cause demyelination, and also extrapontine demyelination can happen also. So patient will present with features of symmetric symmetric upper motor neuron lesion. So patients more. So here is a statement. A patient more susceptible to CPM include those with a history of, so who are susceptible to this more: malnutrition, patient having malnutrition, alcohol use disorder, chronic liver disease, hyperemesis gravidarum. Patient most commonly have a history of rapid sodium correction greater than 0.5 to 1 milliequivalent per liter per hour. Mostly it is more than 12, okay, milliequivalent per liter in a day. Most susceptible patients are those with chronic hyponatremia, more than 48 hours. This timeline is important with severe hyponatremia. The onset of symptom is usually seen in after 1 to 14 days after electrolyte correction. Clinical features are mostly damage to upper motor neurons and generally present in a biphasic course. Initially, patient present with acute encephalopathy and seizures that typically resolve as normal sodium levels are restored. This is later followed by clinical deterioration 3 to 5 days later. Dysphagia, dysarthria, spastic quadriparesis, mostly upper motor neuron lesion, pseudobulbar paralysis, ataxia, lethargy, locked-in syndrome because of one-time lesion. Okay, so this is very deadly. So that's why this is the one-time demyelination. Okay, so prevention: sodium not to be corrected more than 8 to 12 milliequivalent per 24 hours. However, in patients with hyponatremia lasting 48 hours or of unknown duration, the rate of serum sodium correction not be 6 to 8. So 8 to 10 is okay. In cases of severe hyponatremia, less than 120 with neurological symptoms, a hypertonic solution of 3% saline should be administered. Neurological symptoms, if not present, the primary focus should be a slow rate of sodium correction with IV fluids. Okay, does not exceed 8 to 12 milliequivalent per liter in 24 hours. Okay, and regular monitoring of sodium level in blood. So, this is the crux of our whole discussion. So I will try to give a outline to that what we are doing. Any kind of hyponatremia, actually, any kind of acute severe hyponatremia. Severe means with neurological symptoms. You will aggressively correct hyponatremia, and the target is 8 to 12 milliequivalent per liter. Then you gradually correct it. In case of chronic hyponatremia, so this is the thing. So before doing that, you send urine spot sodium. You try to do urine spot sodium. Now see, you do the whole workup that I have shown in the Harrison chart. If it is more than 20, if you are suspecting CRD, you have ruled out diuretic use, you have ruled out any kind of, you are not, also around with urine spot sodium, you are checking thyroid status, you are checking cortisol. Okay. So this is the main workup. So any kind of severe hyponatremic patient, you are aggressively trying to correct it. Any kind of chronic hyponatremic patient, you are uh, slowly correcting it with normal saline and a little bit of, if it is CRD, a little bit of urea or initial IV 20 mg furosemide is you can give. Okay. So this is the crux of management. So take away points. Take away points. Yeah. Try to check volume status. Volume status. Okay. Then determine whether it is hypovolemic, hypervolemic, or euvolemic. Okay. Try to check volume status. Then what you are doing, uh, you are checking urine sodium. If hypovolemic, urine sodium is high, so that means there is renal loss. So why renal loss is happening? Maybe AKI. You check creatinine, urea, etc. Maybe it is AKI, or maybe it can be due to excessive diabetic use, or maybe it is due to some kind of renal tubular RTA use, do ABG, etc. Okay, and if in such cases, hypovolemic urine sodium is low, you are thinking about GI loss or third space loss, like pancreatitis, burns, etc. You can see clinical examination, history taking. And euvolemic, you are doing these these investigations. Along with that, uric acid, you are doing uric acid less than 4, it is highly suggestive. Uh, so if cortisol is low, possibly it is going through to glucocorticoid deficiency and secondary adrenal insufficiency. In case of euvolemia or hypothyroidism, you look for, always don't miss any case of a patient presenting with like a patient presented to us of nearly 60, 70 years of age. Patient was recurrently was hyponatremic. Patient was presenting with recurrent hyponatremia. He was being treated conservatively every time with 3% NaCl and all. Doing that, patient was not on diuretic or something, but the sodium was persistently coming low and potassium was high normal. It was like 4.9. Potassium was high normal. So urine sodium was also high, more than 20. And we thought about this could be a case of whether there is any pituitary lesion that is causing it. So we went for MRI, hypothalamo pituitary axis, hypothalamo pituitary axis, and we found adenoma, pituitary adenoma, large pituitary adenoma. It's in old male, and that was the cause. That was causing the compression there, and that was causing this hyponatremia. Okay, so this is the crux of it. So try to assess volume. Then after volume assessment, do check urine spot sodium, etc. And if patient is acutely hyponatremic, give 3% initial, correct it aggressively, and after that slowly correct the sodium. Okay, thank you very much.